joint meeting of European Federation of Neurological Societies and European Neurology Societies, joint meeting, satellite symposium, titled Time for Change, Evolution of Real-World Evidence Outcome Measure in Multiple Sclerosis, organized by Novartis Pharma. Before starting the session, I will give you some information about housekeeping, but first of all, I would like to introduce myself. I'm Mefkure Eraksoy, professor of neurology, and I have been working in Istanbul University Department of Neurology and directed multiple sclerosis unit since 35 years. I have some disclosure, as you've seen here. And now, before starting the session, I will give you some housekeeping information. Please do not forget to switch off your phone, mobile devices during the presentations. Please write any questions that you have on question cards and hand them to a representative between presentations. The memory stick that you have been given contains Atlas of Multiple Sclerosis 2013 from the Multiple Sclerosis International Federation. Please, again, don't forget to complete the evaluation form and hand this to a representative as you leave the room. Before starting this session, I will give you some brief summarize about getting to real-world evidence. As you know, randomized controlled trials generally give us information and data about the efficacy and the safety of the treatment with a defined, well-controlled settings. And once a treatment is available, the first real-world evidence that we have come from the day-to-day use in clinical practice. And then we begin to build a picture, building up some small numbers of patients to a wide range of evidence. And once a treatment becomes more widely used, the majority of the data come from that information as from the effectiveness of the treatment comes from the real-world evidence. And just before the starting, I will review the overall context of this program. We will have 3 distinguished speakers in the session. First speakers will be Helmut Butzkueven from Australia. He will deliver a presentation on relevance of systematic real-world data collection of physicians and patients. And then the next speaker will be Tjalf Ziemssen, Professor Tjalf Ziemssen from Germany. He is going to talk about collection of real-world evidence and use in clinical practice and research. And the next speaker from United States, Professor Robert Zivadinov, he is going to speak on evolving the evidence-based importance of collecting imaging measures. And then I will give you a brief summary about this session, and then we move to follow question and answer session and close this session. And now, sorry. Can be back, please. Before inviting the Professor Helmut Butzkueven, I will give a brief summary about his biography. Helmut Butzkueven is Associate Professor of Neurology and Joint Director of the Multiple Sclerosis Service at Box Hill Hospital, Melbourne, and Deputy Director of the Melbourne Brain Centre at the Royal Melbourne Hospital. Professor Butzkueven's specialist research area include the development of new biomarkers of axonal degenerations in multiple sclerosis and understanding the effect of MS risk genes. And now I would like to invite Professor Helmut Butzkueven to deliver his presentation of relevance of systematic real-world data collection for physicians and patients. Please come in.
Thank you for the kind invitation to present at this symposium. I'm standing here to try and convince you that you can collect data if you see MS patients, and that these data can actually become incredibly powerful if they are aggregated. These are my disclosures. Data collection, writing down data, is at the heart of clinical practice. These are called medical notes, and they used to look like this. It's very easy to put information into these medical notes, but it's actually quite difficult to get information out, especially with doctors' handwriting. And research used to be completely separate, done on questionnaires, sent to some CRO where this was punched into a computer. But these two people, Bill Gates and Steve Jobs, changed all that, really. They arguably introduced useful computers to the real world. And part of that is, of course, the development of electronic health records. Unfortunately, electronic health records are great for hospitals. They're good for tracking admissions, for billing, possibly electronic prescription, electronic test ordering, discharge summaries. But to monitor a disease like multiple sclerosis, we usually need something more than that. Of course, these kind of data that exists in electronic medical records become big data, and analytics of big data can describe overall global trends, but it may not be enough to really learn about individual outcomes. A registry, a prospective data collection, a cohort study is more than that. Not much more. And this is a slide from the EDMUS website, EDMUS being the French data collection system. It really just emphasizes one thing. People who do this together have to agree on one language, the language of multiple sclerosis. After you agree on a language, which includes demographics, relapse onsets, EDSS scores, and codified MRI and diagnostic testing, can you implement this as a physician-initiated registry in clinical practice? I hear many skeptics saying that, well, we don't have time to do this, and that may be true, but on the other hand, if we're looking at the Danish National Registry, particularly the Italian IMEDWeb or National MS Registry, EDMUS in France, MS Base, organization that I represent globally, the Swedish National Registry and others, 150,000 or more records say it isn't so. You can do it. Admittedly, most of the really successful programs in the world are hybrids. And by hybrid, I mean that we have a system which can serve as registry functions, but it also provides features of an electronic health record. And I'll show some examples of that. Here's the Swedish registry. 80% of Swedish MS patients are monitored using this system online. And what it provides for the clinician is data on treatments. You can see here, for example, Avonex, Rebif-Mitoxantrone, Tysabri, relapses, and disease scores, the EDSS scores. And you can also already see a little bit of extra feedback. This line at the top here is actually a line that describes the severity of disease relative to other patients. So you can get some comparative evaluation immediately. MS is a long history disease, and this is using the IMED medical record that we use in Melbourne, and many other centers around the world use. And because this is a disease that goes over decades, the information becomes incredibly complex. And you can't keep it in your head. And if you don't have it in an electronic system of some sort, ideally with a graphical display, then it's very difficult to manage your patients, at this point without really knowing the past. Here you can see someone with 10 years of MS. It's interesting. Lots of relapses on Rebif, lots of relapses on mitoxantrone, relapses being these red dots here. Completely shut down disease activity on natalizumab, then JCV positive changing to a fingolimod, and neurological scores getting worse and worse and worse, and then actually improving. What happened with MS base is this. Is the idea, originally actually from the pharma company Serono, that this type of data could be accumulated anonymously after ethics approval and informed consent into a mega database called MS base. Now in 2004, this vision became independent and actually incorporated as a not-for-profit organization in Australia. And I'm very pleased to say that this vision has been very successful. We're now monitoring well over 30,000 patients, and if anything, recruitment into the system is accelerating significantly. The countries that are heavily involved is most of all Italy, that have a system where records can be jointly sent either to the Italian registry or to MS base, and Australia, which is good, Canada, Czech Republic, Spain, Netherlands, and then Turkey in eighth position at the moment with some 1,500 records. So we have over 150 participating neurological clinics with over 30,000 patients, and we have about 5 years follow-up on average on these patients. The people participating in MS base are data lovers. They're giving us EDSS scores approximately every 4 to 5 months on average. Almost the same density as exists in clinical trials. And importantly, everybody agrees on a small but important minimum data set. Now, what can this deliver back to you as a clinician? Well, one of the things that it can deliver immediately is benchmarking. Actually, the MS-based server provides this service to all clinicians free of charge. It draws a mean disability curve, actually a median disability curve, according to disease duration. This is for the relapse onset patients in this example. We also have one for primary progressive. And this is the 25th and 75th centile. So if you put your patient's data in, only an EDSS score and the disease duration, we will tell you that 4.5 at 6 years is on the 90th centile of disease severity as generated from over 12,000 EDSS scores. You can then do with that information as you wish, but it provides benchmarking information. We hope that in the future, this kind of information can expand so that we can give true second opinions on outcome and prognosis to our physicians. The theme of this symposium is real-world data, and there are many kinds of real-world data. The only one that isn't really is the randomized trial. This is about comparative efficacy that usually goes for 1 or 2 years. I've spoken about the MS registry, and for completeness, there are also claims databases, and Professor Tjalf Ziemssen will talk about that in the next presentation a little bit. And there are population-based registries that try to capture every case, usually at much lower density, and then pharma or independent observational studies that might be monitoring a single pharmaceutical product for a long period of time for safety and efficacy. Arguably, real-world data is absolutely required to answer the big and important questions in MS. The big and important questions are things like, how do drugs compare to each other if we don't have RCT evidence? How does a treatment decision today influence outcome in 5 or 10 years? Well, you need 5 or 10 years of data to answer the question. Do drugs really work to prevent long-term disability accumulation? The doubt about that is declining, but it's still a question. Do relapses, do pregnancies impact on long-term disability progression? Do drugs work in progressive MS? And the big question, can we individualize treatment to maximize benefit-risk ratios in the future? So I'm going to give you an example of an answer to one of these questions from our registry. The question is really quite simple. You're on interferon or glutaminyl acetate injectable, you have a treatment failure, a relapse with a significant change. And you decide, as a clinician or as a patient, that it's time to switch. Now, you might switch between these products, for example, transitioning from interferon to glatiramer or vice versa, or moving from Avonex to Rebif, for example. Or you might choose to change to fingolimod, and at the moment, we are providing evidence on 12-month follow-up after this treatment decision. So more specifically, we selected patients who had an on-treatment relapse in the prior 12 months, who switched to either fingolimod or between the injection therapies, and we assessed persistence, time to next relapse, and annualized relapse rate. The problem in the real world is that you don't have randomization, so that your baseline variables are not going to be well matched. How do you deal with that? Well, one way you can deal with that is to actually record everything that you know about the patient in the database. So, for example, the EDSS score, the total relapse onsets in the last 1 or 2 years, sex, age, treating center, country, disease duration, previous treatments. Based on all of these characteristics, you can use a statistical method called the propensity score to give you a probability on what treatment the patient actually ended up. In this example, 0.41 means a 41% chance of ending up on interferon glutaminyl acetate, a 59% chance this patient was moved on to fingolimod. And then, on the basis of this probability that we call the propensity score, we find individuals in the two groups that we want to compare that have the same propensity score. This is our population to study further. To put it another way, if you randomize, if you have a randomized controlled trial, your probability of ending up on treatment A or treatment B is 50-50, right? 0.5. In the real world, your probability of ending up on treatment A or treatment B is not the same. But if there's overlap between the curves, that is a population we can study. To put it yet another way, we remove all of the patients with, say, very mild or very severe disease that we can't match. So how does this pan out? Sorry, if I could go back one slide, my apologies. Thank you. We found just over 500 patients who met all the switch criteria and you had appropriate EDSS scores at the right times. And we could see that by the p-values here, in certain characteristics, the patients are not well matched. For example, disease duration was almost 50% longer in the switch to fingolimod cohort, and also the number of treatments that the patients had previously been exposed was different between the groups. After propensity score matching, where we found 208 perfect matches, we eliminated actually all of the baseline imbalance. In this study population, now examined forward, we can see the following things. Firstly, patients who switched to fingolimod stayed on the medication much longer than patients who switched between injections. A 78% reduction of treatment discontinuation for fingolimod. And arguably, this is the most telling statistic because if your patient doesn't take a treatment, then it can't work. Time to first relapse was significantly prolonged on fingolimod compared to the injection switch, in fact, by 45%. Here's a measure that you're more used to from randomized clinical trials, which is the annualized relapse rate, which was reduced by 46% in the switches to fingolimod. The question can be, can we trust this data? Is it reliable? Well, one way that we can check if we're close is in a situation where we actually have a randomized controlled trial. Because if we have that, we could see if we can reconstitute the results in something like MS-BASE. We don't exactly have this trial, but we have something close, and that's called a transforms RCT. Here, patients, approximately half of whom were on treatment, usually injection treatment, at the time of randomization, who had had a relapse in the last 12 months, were then either changed or transitioned to Avenex or fingolimod in a double-blind, double-dummy RCT. And the relapse rate reduction in that trial was 52%, which is actually very similar to the figure that we produce. So I want to conclude by saying really that I hope I've convinced you that an MS registry program in your practice, especially if you're seeing a lot of MS patients, will help you to manage the condition better. If you then participate using this kind of EMR, electronic medical record, MS specific for, if you participate in a registry, such as MS-BASE or others, you can add value through benchmarking and decision support. These systems, I think, are our only chance to generate long-term safety and efficacy data in multiple sclerosis that is clinically meaningful to our patients. And it might also give us a chance at personalized medicine, especially if we combine it with biomarker data. I've also shown you that data that isn't collected in RCT can be benchmarked against NATI's RCT if such an RCT exists, to show validity and improve confidence in the registry-derived results. So finally, an advertisement if you like, www.msbase.org. If you press this button here, your world will change forever. Thank you for your attention.
Thank you. Thank you very much indeed for this nice and comprehensive presentation, Professor Butzkueven. Our next speaker will be Professor Tjalf Ziemssen. Before inviting him, then yes, I will give some information about his biography. Professor Ziemssen is Professor of Clinical Neurosciences and Head of the Center for Clinical Neuroscience at the Neurological University Clinic Dresden, Germany. His research interests include the role of inflammation in the brain, monitoring of immunomodulatory therapies, mechanism of autoimmunity and tolerance in multiple sclerosis and experimental allergic encephalomyelitis, and multiple sclerosis documentation and management. Yes, please, Professor Ziemssen.
Thank you very much for the kind introduction and for giving me the possibility to present real-world data here in Istanbul. So I'm now the person who is responsible to get all the rest of you who not believe that real-world data are important. So I do the second part. I think Helmut was very impressive, and I will try my best to show you that real-world data are really very helpful. That are my disclosures. You have seen that by the means of real-world data, you can even simulate clinical studies, the Transforms ICTs with the MS-BASE registry, what you have seen. But we have other tools to look at real-world data, and they are in principle quite important because the pharmacoeconomic view is getting more and more important. That's why I think it's quite helpful to look at claims databases, observational studies, and population-based registries. So if you're looking, for example, at the claims databases, that's a very easy way to get data. So if someone has to pay for the drug and for the services, and these data are collected, of course, it's a very helpful tool to look at this data and to understand, so what are the resources utilized in the setting and what are the medical costs, especially for drugs. And one of the big players in the United States is the PharMetrics Plus claims. That is, in principle, a company who's responsible for, or who buys the data which are relevant for the interaction between patient and healthcare providers. And a lot of different data are generated by these claims databases. So, for example, for the MS claims database, this specific PharMetrics Plus claims database, we have data on more than 200,000 patients with MS, and they have been diagnosed between 2006 and 2013, and all the relevant data have been collected. And if we look, for example, here, again, in a claims-based relapse rate comparison between, in this case, glatiramer acetate and fingolimod, you can see that it looks like the analysis we have just seen by Helmut, that in this matched cohort group, the patients switching from interferons to fingolimod are doing better in comparison to the patient who switched to glatiramer acetate. On the other side, you can look at other important parameters. So not only the relapse rate itself, but you can have a look, for example, at resource utilization, which is, of course, important for the quality of life of patient, for the money which is invested in the patient. For example, on the left side, you can see the inpatient visit before fingolimod, and then reduced by 70% after switch to fingolimod. And the same is true for the day's supply of corticosteroids, so you can reduce the amount of corticosteroids applied in this setting. So I think it's very helpful because it's independent. The payer has, of course, interest that neutral data are generated, and that's why I think it's a very helpful tool, just nicely published this year, to get more insights in different effects, safety profiles of drugs. Another approach is, of course, population-based registries, and there, especially our colleagues from Scandinavia are very familiar with this population-based documentation. And of course, if you have a whole MS population and you look for different drugs with the same strategy, Helmut has already introduced you to the Swedish registry. Of course, it's quite interesting to have a look at long-term data, but even then on specific parameters documented in this population-based registries. And here, the example of the Swedish MS registry, of course, not only patients on a specific drug are documented, but patients on different drugs are included, and different parameters, demographics, treatments, EDSS, relapses, and MRI is documented in this registry. And in the Swedish registry, you have seen it in the overview in Helmut's presentation, more than 12,000 patients are documented. The registry was set up in 2002. And if you look, for example, here in the subgroup of patients treated with fingolimod, the IMSA-2, so a specific subgroup analysis limited to the patient who started on fingolimod. You can see 44 centers did participate, and you can see here the study which started in 2011, 800 patients are documented, and you can see here, for example, what is usually interested, what is the history of the patient, whether they came from the classical basic treatments or whether they switched from natalizumab. And yeah, of course, you can have a look besides this baseline data, which are the characteristics of the patient, but you can have a look at the changes of this patient. And here you can see, of course, the change of annual relapse rate before treatment and after treatment. You can see the stabilization of the EDSS, which is performed every 6 months. Of course, especially if we have more long-term data available, of course, it will be very interesting to go in specific subgroups. But what is the charming thing about this documentation is that not only standard parameters like relapse rate or ZDSS are included here, for example, more innovative parameters like the MSSS or cognitive function, the SDMT, or patient-related outcomes. Here the EQ5Ds are included in this documentation. And of course, that is very helpful because we will generate long-term data. Of course, the different drugs are documented with the same infrastructure. And that's why I think we can wait for very interesting data which will help us in the future. Of course, at the end, we have to come to observational studies which are dedicated to one specific drug. Because I think, of course, you can go the approach like we have with, which is already implemented in an MS space, to use the same minimal data set to document your patients. But on the other side, I think every drug is different. And so my philosophy is that especially with the more innovative drugs, documentation is not the whole story. We have to learn to manage patients. We have to look for specific adverse effects. We do know that specific procedures are necessary. And that's why I believe that, of course, we need a minimal data set. But on the other side, we have to focus especially to the management of specific drugs. We have to look for specific side effects, which we know from the clinical trials, and to combine this, of course, with the long-term efficacy of this drug. And one example which we implemented in Germany, it's the Pangea trial, which is a prospective observational trial where we try to get as many as possible fingolimod patients included. And so we will have 5 years data available when we will not extend the trial to get more long-term data. And we ask, of course, different parameters which are specifically related to fingolimod. On the other side, of course, we have a certain minimal data set to compare it with other parameters, and the registry at the moment has 4,200 MS patients included. For this purpose, I have told you that documentation is not not enough. We have a long-term interest in not data basing, but to generate software tools to provide data and to collect data. So already in the late 90s, the first MS documentation software was developed in Dresden, and now we have the most recent version, the MSDS 3D version, which is used for the Pangea documentation as well. It could be used as a web tool. On the other side, it's a local software which can really work with the patient names. It can interact with various infrastructure. Of course, we can do the clinical documentation, but we can include specific treatment management for the different, more complex drugs, like, for example, alemtuzumab, natalizumab, and, of course, fingolimod. We can link it up to different registries. So, for example, it's possible to use one software to send the data to our MS registry from the German MS Society, or to the registry of the Competence Network, or to other registries. And, of course, scientific projects dedicated to specific questions could be started. And the infrastructure is very innovative. So the data are in principle in the cloud, but of course safe, and it could be used, the software can interact with the patient. So we have, for example, the patient can use the iPad to enter patient-related outcomes. All communication with the patient could be done with this platform. We can present cases inside the software to discuss, so to provide second-level support. We can include the neuroradiologist in this system. And on the other side, of course, we can send the data to the registry, because we have, in our opinion, it's very problematic if you have only the possibility to document, because then you have not, you have not the need to really collect all the data which are necessary. That's why we have, in this structure, we have different modules, and these modules could be adapted to the need. And you can see here, each visit has certain visits which have to be performed. Most of the work is done by the MS nurse. Only important things like adverse effect reporting and so on, it's done by the physician. And by the help, we have now collected the German fingolimod group in the Pangea registry. On the left side, you can see the previous disease-modifying treatments. And for example, we will have a small group, but anyhow, we'll have a group, for example, from patients switching from immunosuppressive drugs to fingolimod. The majority, of course, is switching from glutamer acetate or interferon, but of course, especially the switch from natalizumab, which I will refer later on to, is of interest. You can see the EDSS, the different EDSS groups. You can see some patients are started at a low EDSS, some patients are started at a higher EDSS. Of course, it will be interesting to look for these different groups, lower EDSS, higher EDSS in the future. What will be the outcome of this patient? Interestingly, that we see changes over time. For example, we see the tendency that fingolimod is used over the time period in patients with lower relapse, previous relapse rate, and in patients with lower EDSS, as you can see on the right side. So you can see over time tendencies in the neurological group of in Germany that there is a change behavior of fingolimod prescription. If we are looking at the analyzed relapse rate, of course, we have the documentation before and later on. You can see, for example, that there is not a significant difference if we compare the switch from interferons to fingolimod or from glutamer acetate to fingolimod. Of course, it's very tricky. I will come in the next slides to it, the switch from natalizumab, because the natalizumab patient is usually stable, but during the washout, of course, activity can come back again. And you can see if you start fingolimod without any previous immunomodulatory treatment, it's working as well. And you can see the lowest relapse rate in the first year. If we are looking at the EDSS data, it's quite interesting that there is significant change possible in the first 18 months. So after probably 2 years, you can see that it has settled down, that the patient usually keep the stable EDSS. In the first 18 months, you can see a quite significant chance of improvement. Of course, some patients, they present with a sustained EDSS progression, but we will of course, look at this patient population in the long term. I have already told you that especially the natalizumab group is of interest. You have seen last year at the presentation that the TUFINGO trial, a trial evaluating different washout time intervals for the switch from natalizumab to fingolimod was of interest. Here, we documented the washout periods which have been used by the different neurologists and collected this data. You can see we have a huge variety of different washout periods in this group. And looking at this group, you can see that, interestingly, the length of washout, it's responsible for the relapses in the washout period, as indicated on the left side, but that there is no significant difference if you look at the relapse rate in the first half of fingolimod treatment. Yeah, so, of course, we would advertise not too long washout to avoid relapses in between, but you can see that the first half year on fingolimod is quite comparable between the different washout intervals. Looking at the adverse effects, of course, we can see that the adverse effects are the same as we know from the clinical trials. So we know adverse effects linked to the mechanism of action, lymphopenia, that's what we are interested in, lab results, and so on. So I think it's quite helpful that in real world, we get the same safety profile as we know it from the clinical trials. Here one example, the first dose monitoring. So what happens if more than 3,500 patients are first dose, you can see only an event rate of 63 cases, and you can see here what happens when prolonged monitoring was necessary. I think quite promising data and quite reassuring data that the first dose monitoring, we do not demonstrate a lot of significant findings, and that it's that fingolimod, especially on the first day, is a very safe drug. Of course, if you look with the database lock at January this year, it's a mean observation time of 443 days. If you look at the discontinuation rate, you can see that only 12 patients discontinued fingolimod treatment, and I think that's the same results we saw from Helmut, quite impressive data, that most of the patients, they continue, and the physicians, they like the management using Pangea, that it's really an assistance for them to guide the patient over time. And for example, my patients, they're quite happy that they enroll and that their data could be used for the next patient generation to get some data on it. Of course, it's very interesting, and that will be the end of my presentation, whether we will have a comparative group. And we are quite lucky because with the same methodology of the Pangea trial, we evaluated with the so-called PEARL trial, an observational study where we observed patients on baseline therapy for a period of 2 years. You can see here 1,700 patients, so 2/3 of them on interferon, 1/3 on glatiramer acetate. And by the help, by the prospective documentation of the patient, you can of course identify the patients who fulfill the fingolimod label, patients with activity, and you can create a PEARL active group, and you can compare it, for example, with the fingolimod group. So you have an internal comparator between these groups. And if you look what happens to patients relapsing on baseline therapy, in contrast to the fingolimod group, you can see here what happens in these prospective cohorts with a pre-planned analysis. You can see here the increase of the EDSS in the PEARL active group, so on the of the patients with on immunomodulator, and you can see the EDSS change, which was the opposite in the fingolimod group. The same is true if you look at the number of relapses, quite significant decrease or lower relapse number in the fingolimod group in comparison to the active baseline therapy group. And you can do the same as I have shown you in the claims database. And I think the nice thing about this is that we see the same data presented in different registry, which is of course very important for that the data are valid and reliable. So we can see here the pharmacoeconomic side of PEARL and Pangea. You can see the numbers of days without MS medication, taken sick leaves in the last 3 months, hospitalization, consultation with physicians, which are in favor of fingolimod. And I think that are very important data which we will present to the payers, because at the end it demonstrates that the patients are doing better, and of course that in principle it means saving resources in addition to the increased quality of life. I have shown you that a lot of data have been collected in the real world, but there is still a question mark, because both of us, so Helmut and me, we have not discussed the question mark. And that is now the cliffhanger to the next presentation. And I thank you very much for your patience listening to me.
Thank you very much indeed for this nice and interesting data shared with us, Professor Ziemssen. The next speaker will be Professor Robert Zivadinov, and I would like to invite him. And before starting his talk, I will give his biography to you. Professor Robert Zivadinov is Professor of Neurology at the State University of New York, SUNY, Director of the Buffalo Neuroimaging Analysis Center at SUNY, Director of MR Imaging at the Clinical Translational Research Center at SUNY, and Clinical Professor of Neurology at Florida International University College of Medicine. His research interests include quantitative magnetic resonance imaging and research into venous function in multiple sclerosis, as well as measures to assess neuroprotectivity. Please, Professor.
Thank you very much. It's a great pleasure to be here, and I hope to introduce you really the last component of link to the other two presentations, which is really how can we collect imaging measures and what we can do with them. So first, my disclosures. My outline of the talk will be really introducing you some clinical routine sequences and recommended protocols, because without those, clearly we can't do collection of the data, because we need first to acquire the data. Then we will discuss whether collection of MRI data is feasible in clinical routine and what are the really general requirements for that. And I will show you some experience with long-term MRI databases. So I'm sure all of you who follow MS and in general neurology patients are familiar with these sequences. And while we are using them for the last 20 years, the improvement in scanner technology is rendering these techniques every day more sophisticated for performance of quantitative analysis. We all know that T2 and FLAIR are very important sequences in a clinical routine for recognition of hyperintense T2 lesions. We also know that T1 spin echo scans are important for recognition of acute inflammatory activity, which shows the breakdown of the blood-brain barrier, gadolinium-enhancing lesions. And also sometimes these lesions, about a third of these lesions over time, evolves in what we call chronic hypointense lesions or black holes. They are mostly related to neurodegeneration in MS patients. Then is one sequence that's very specific and very quick with improvement of techniques, about 3 to 4 minutes, to acquire high-quality images 3D-T1 of gray matter volume, white matter volume, and cerebrospinal fluid volume. Usually we use this technique in academic centers, but also in the community ones to perform quantitative image analysis. But tonight, I really would like to give you a little bit different message, that it's really not necessary to acquire this sophisticated sequence in order to perform quantitative analysis in patients with multiple sclerosis. Certainly is preferential. So there are a number of different guidelines which evolved over the years for use of different brain and spinal cord MRI protocols, and I'm just presenting one for the sake of time, although this is the North American one, although there is also pretty recent European one. And as you can see, the sequences I showed you, including PDT2, axial flare, T pre and post contrast, and 3D-T1 are the essential sequences. There are also improvements in the newest scanners where you can acquire three-dimensional flare sequences that can give you different orientation of the slices, including sagittal, coronal, and axial. So there are a couple of points to be really underlined respect to this brain protocol. One, it can be done at 1.5 and 3 Tesla scanner. Two, the recommended slice thickness is 3 millimeters without gap. While this was really problematic to be done in the past because of time, I would say that in the last 5 to 10 years, it is really achievable to get this protocol without gap and using 3 millimeter sequence for these sequences and 1 millimeter for 3DT1 in less than 30 minutes, especially thanks to the use also of parallel imaging techniques which are acquiring signal using 2 coils. So, is collection of the MRI data feasible in a clinical routine? There are some general requirements. First, we need to provide the technological resources to perform accurate and reproducible analysis of medical imaging data from which some both routine and scientific conclusions can be drawn. We need to maintain data integrity and confidentiality, and which is the most important probably for the talk tonight, ensure the data collection and its future availability as the techniques are constantly evolving. And what was not possible yesterday, maybe it will be tomorrow. We also need to make the workflows involved as efficient as possible because many of these techniques are becoming fully automated. They make very little or no error and can be really used on a clinical routine basis. So what's the general flow? We need to receive the scans, to store the scans, to analyze the scans, but also ensure scan analysis quality, as well as store the analysis for future use, especially regarding the longitudinal data, and maintain the data integrity, and clearly bring the data in less than, I would say, couple of hours back to the physicians. So to report the data, so they can use them really in real time. How is that possible? Now, in many MS centers and MRI centers across the globe, there are PACS systems. I'm sure you are all familiar because you are looking on an everyday basis your images of your patients in these huge database network systems which are storing the DICOM files, the original files of the MRI images. And then these images can be transferred to specific centers. So clearly, when you get into this third component, then I think the things are getting a little bit tricky and are more site-specific, center-specific. But I would say that this storage of the images in the PACS system is extremely important for allowing future generalizability of data analysis. Clearly, these systems are expensive, but really now for less than $10,000, you can really get very powerful systems due to the decrease of price of technology to perform analysis on a large amount of data. Now, it's not just enough to have these computation storage systems, but when you begin to do the automated analysis, it's extremely important that everything is as automated as possible, including automated reading of the DICOM files, ensuring consistent workflow, accuracy and efficiency, but are we going ever to be able to produce this data without the operators? I would say that the role of operators in the future will not be, or it is even not now, to perform the analysis, but just to ensure that the quality of the analysis is acceptable to be used on individual patient basis. And so computer perform analysis as much as possible, and then operator performs only what requires human interaction before the computers again continue with the analysis, and quality checks are along the way. Now, Let me give you a couple of examples. So our goal is to reduce or remove scanner errors, especially because sick MS patients try to move a lot. They have a lot of artifacts. To diminish variability, prevent unanalyzable scans, and increase power to detect effects earlier and on smaller groups. And I can tell you that my center has been involved in many phase 1, 2, 3, and 4 clinical trials, really analyzing thousands and thousands of images from many, many centers. And I really believe that we are able, not just our centers, but we are able to minimize really the acquisition error that can be correctable with post-processing. So which are these post-processing tools that are kind of running behind the scenes and that you are even not aware of them? One of the most important is non-uniformity correction. So what's that? As you know, based on a patient motion and also on the scanner and head position as well as on the scanner, there is an inhomogeneity. So you can see it that there are clearly tools, many different tools, that can correct these scanner errors and completely perform adjustments of the scans without changing any quality. Maybe the most important tool in a clinical routine would be use of co-registration. This is a three-dimensional realignment of images, extremely important for longitudinal scans because of positioning errors. And sometimes I would say that in MS, we are clearly reporting new lesions which are really not the new lesions, but are just due to the positioning errors. So co-registration is a key component in image pre-processing. And both of those techniques can happen automatically with basically zero errors. So once you are improving the scans in very little or no times, in times of seconds, you can think about performing quantitative analysis. And you can see a great deal of different types of analysis, which I divided in focal, macroscopic, and microscopic. And I'm sure you are familiar with all of them. But are we ready to use them in a clinical routine? I really think that we are ready to use three: the lesions, T2 and T1, and brain atrophy. So let me give you an example how can qualitative analysis of lesions help you easy your time in looking on the scans. These are two longitudinal scans of a same patient, and when you look the flares, yeah, it's visible that there is a new lesion, but subtraction imaging is really a new technique. It's a post-processing technique that's clearly giving you an idea where this new lesion is happening. And I think would be a great deal to use it in a clinical routine as we are doing in Buffalo. There are many atrophy measures, and as you all know, atrophy is extremely important outcome in both MS clinical trials as well as in predicting disability. And here the situation is a little bit more complicated. Why? Because not along the disease process, all measures are always reflective of what's happening in MS patients. So in very early disease, we have thalamus and other deep gray matter structures really evolving more rapidly in CIS or early relapsing remitting patients than in normal controls. Later on, that's mostly related to gray matter as well as cortical atrophy. But one measure that's very independent of disease course and that's evolving linearly across time points is lateral ventricular volume. It's very predictive of clinically definite multiple sclerosis. It's very predictive of disability development, whether you are talking about CIS patient or you are talking about patients with secondary progressive disease. Certainly there are other components like corpus callosum in the white matter that also have to be considered. Now, Can we use these measures on a daily basis? If you look at an atlas of 26 healthy controls and 98 relapsing remitting patients, you would say they look the same, but they are actually about 14% different. So clearly by visually defining these changes is almost impossible. That's why we need to move to quantitative tools. So is it possible to do these quantitative tools in a clinical routine? I would say yes, because the quality of MRI sequences is really improving dramatically, because it's much easier to collect the images, store them, and to use this huge database system with analysis pipelines to analyze them. Pre-processing is making a dramatic difference in improving bad scans into good scans and allowing reliable analysis. And if we begin to focus more on how to make simple these measures that are so important in follow-up of MS patients, I would say we can really begin to make a difference. So last 5 minutes of my talks are dedicated to really world experience of these measures in collaboration with some groups around the world and ourselves. So in collaboration with Charles University of Prague, and particularly with Professor Havardova and Horakova, we are working now for more than 10 years on collection of data from a very extremely valuable clinical trial called Avonex-azathioprine steroid clinical trial, which obtained in 180 early relapsing remitting patients twice every 2 months a scan in the first 2 years, and then yearly up to 10 years. So this is the only database in the world in which the scanner has not changed, as well as same tools and coils have been used to acquire scans over 10 years serially. And I'm going to show you some data from that study at 5 years. We are in process of concluding the 10 years analysis, but the 5-year data showed very good correlation between disability progression and whole brain, as well as cortical atrophy, and you can see also enlargement of the lateral ventricles, where there we did not see correlations with the T2 lesion volume. Now, there are also other data, for example, our Buffalo experience. We are collecting 2,500 MS patients and 40 healthy controls on 2 scanners, 3 and 1.5 over 8 years. Our protocols are standardized in a clinical routine. The transfer occurs on a daily basis. The data are stored in a centralized systems. Fully automated computational systems are running the analysis. They are overwritten by the operators and checked, and these data are available for physician use. So let me give you an example. This is a patient who has approximately 30 milliliters of lesions, so with 20 years of disease duration. That, I would say, it's quite representative. Similar black hole lesion volume, it's about 1/4 of the, or 1/5 of the T2 lesion volume, and based on a healthy controls, age and sex matched, and on thousands of MS patients, sex and age matched, based on this higher lesion volume, this patient falls a couple of percentiles, I would say, maybe 25 percentiles below the line, which means has more brain atrophy. And it fits well because you can think more lesions, more atrophy. But this is another example of a patient who has very little amount of lesions, much less than what's expected for his disease duration. You can see the same for the black holes, but his brain atrophy is actually more advanced respect to what you expect. And we all know that patients like these are difficult to treat because we believe that they do not develop lesions, and we ask ourselves how they progress. And they progress because clearly the brain atrophy advances. So to do the brain atrophy in a real world, in a clinical routine, I think should be our goal. So I would conclude by saying that improvements in standard MRI protocols allow really for quantitative data assessment in most of the academic and community centers across the world, including those from Eastern Europe and India, because we are doing a lot of trials in this country, and I can certainly judge and witness that their MRI protocols dramatically improved over the last decade. I would say that PACS and other storage systems are now available in every center to allow easy MRI data transfer and collection. And the software improvements in MRI analysis are really closing gap toward application in a clinical routine. I'm fully convinced that systematic MRI data collection on an individual patient basis is possible, is feasible. It has to be further standardized, and I hope I will be on a similar symposium in a couple of years where we will be able to present really results from these MRI data collection systems that are ongoing across the globe. Thank you very much.
Thank you. Thank you very much indeed. This wonderful and comprehensive review and presentation, Professor Zivadinov. Thanks. Have a seat. Yes. What we have heard from the faculty that real-world evidence is a very important part. What is missing in real-world evidence? We can see. Yes, we have heard that what is often missing from real-world evidence is the systematic collection of MRI measures. We are hopeful that in the future, this will become easier for the practicing neurologists, supported by new methods and improved collaborations and knowledge exchange. And also, I would like to introduce the NeuroOnline's platform as an example of how we can share knowledge among the neurology community. NeuroOnline in Turkish neurology online resource with many useful features such as peer-to-peer communication, training, tutorial and educational presentations, access online and offline to therapy leader consultation, case consultation, and ask the expert. This type of resources provide a community where information and knowledge can be changed. By engaging and sharing experience and information, we can all contribute to a better of understanding a real life treatment of our patients with multiple sclerosis. And I'll also give you a summary about this session. Real-world evidence is something that we are generating every day. Your own and our own clinical practice provides first-hand real-world evidence. We can expand on the data from randomized controlled trials. Systematic collection of real-world data evidence has confirmed the effectiveness and safety of fingolimod in the real-world setting. Real-world evidence is strengthened by the collection of MRI measures. By submitting your data to a local or international registry, you can contribute to real-world MS research. And now I would like to invite Professor Butzkueven back to the lectern. Excuse me, sorry. Yes. Back to the lectern to introduce the question and answer session. Thank you for your attention.
Now we're going to spend a few minutes on questions and answers, some of which have been questions provided by the audience. But I'm going to take a privilege and ask Professor Zivadinov the first question. Of course, in your center and in Prague, these are dreams for us, okay, because you are providing brain volumes and lesion volumes and lesion numbers to neurologists in clinical practice. In general terms, the thing that stands between us and this technology being implemented, for example, in our center, is the radiologist. My question is, do you think that there's a place for more centralized reading centers that provide this kind of post-processing as a fee-for-service, you know, where it's standardized, quick, high volume?
I do not. And the reason is because it will be always hard to offer fee-for-service type of data analysis to the centers when there is really difficulty in the budgets, restrictions with insurance companies to offer such measures. However, if you think about Alzheimer's disease, there are clearly ways and centers that are providing. What I believe is that we need to develop very simple tools, fully automated tools that can be provided for free, not for service, for free. So the centers can download these tools by themselves and perform the analysis with click of the button on iPads, on tablets, on PCs, on their iPhones. I think that's the way to go. And I, for many years, have been chasing MRI scanner companies to introduce these quantitative tools. But they always want to be proprietary, and they don't want to make them large-scale basis beyond their scanners. So I think we need to go in a different direction, develop tools like lateral ventricular tool, for example, that can be done on a very low quality scans like T2 or FLAIR, and offer that to be done longitudinally in no time when the physician sees the patient. And clearly that can be only done through the iCloud system.
Well, I dream of this, and I hope that dream becomes a reality.
I hope too.
I have a question for Professor Ziemssen. Is your tool only for German hospitals, or do you plan to extend this to other countries and other communities?
Of course, we plan it because it's a big work we have invested in the last 5 years. And of course, this tool is not only made for German hospitals, but we have already an English version available, and we try to implement it. And we will follow the same strategy as Robert has told you. So we think, of course, we have to get for the investment, but the software itself should be free, the same like the MS-based philosophy. But I think it will be only used in clinical practice if it will be free of charge. And I believe to improve the quality from imaging, from clinical management, that's the only way to go.
I have a follow-up question, which is more specific around some of the data that you presented, Tjalf. What is your idea that in your Pangea data set, there's no correlation between the washout phase and the on-fingolimod treatment relapse rate after natalizumab cessation?
So that's not right. So it's, of course, we see that the relapse rate in the washout period is, of course, significantly different. So if you wait longer, then you have the relapses in the washout phase itself. But if you look at the, which I think it's the very interesting parameter, if you look at these first 6 months of started fingolimod, you don't see a difference whether you waited for a long time or for a short period.
There's a question that I can ask to myself, which is, what are the requirements to participate in a registry? In fact, are these tools for free, including for developing countries? And the answer is definitely yes. You essentially have to be a neurologist, you have to register, and usually you have to have ethics approval and consent forms, or at least follow whatever local regulations apply. There's also a question from Jordan around funding opportunities for registry data collection, which is a big issue. Unfortunately, we know it takes a few extra minutes, and in general terms, there's no specific funding available. However, sometimes pharma companies are interested in supporting investigator-initiated trials, particularly around things like safety, and these can be run independently on registries and still be supported by pharma. Sometimes governments are interested in understanding local conditions and local problems, local side effects, local drug utilization. So both governmental sources and pharma company sources are commonly used to help fund local efforts within large registries. I have a question on treatment algorithm. Tjalf, when do you prefer to switch to fingolimod?
When? Yeah, not too late. So I think what we learned from the registry is looking at the German experience that in the beginning, so German neurologists waited 3 or more relapses until they considered the switch to a more efficacious treatment. And I think that was very helpful, for example, implementing our Pangea study, because we used it to discuss treatment habits in Germany. And on the other side, I think it's the same philosophy as you have in the MS-based registry. The data are there not to be collected in any wardrobe of a pharmaceutical company, but they are there to be brought back to the neurologists who are creating the data. And I think this feedback was very helpful, because we see that fingolimod is not used, or it's not only used in patients above an EDSS of 5.5, yeah, but it should be used to avoid damage to the brain. And I think this purpose, by bringing the data back to the neurologist, it's very helpful.
I guess in general terms, there's a reasonably large amount of evidence now suggesting that in a treatment failure situation, second-line agents, I guess in Europe at least, fingolimod or natalizumab, can be extremely helpful in reducing the accumulation of further damage. Maybe I'll ask you, Robert, and also you, Tjalf. Can you comment on the possible utility of information collected through online patient communities, like patients like me? I don't know if you have any views on that.
No. No.
Tjalf, do you have any?
Yeah, so we try with our system, we try to link the patient and the physician. Of course, I think it's not of course, you can get information from these web pages. For example, patients can report on adverse events and things like that. But I think it's usually quite helpful if you get the full story. And the full story is usually if you get the description from the neurologist and from the patient side. So that's why we developed our system, the so-called 3D system, to get not only information from the physician, but from the nurse and from the patient. That's why I think it's working. But on the other side, my favorite would be to link the data from the patient together with the patient, with the physician's documentation.
So you'd like to join the communities rather than separate the communities.
Yeah.
I think that's a very good summary. There's a question here also about something that I think a registry can't address directly. It's really about risk factors for MS, and specifically asking whether elective surgery might be a risk factor for MS. Of course, a registry or a community could, in fact, rapidly create case-controlled data to answer such a question as a kind of sub-study of some sort. But of course, if all the patients have MS, then you can't answer that question individually.
Can I have ask a question to Professor?
Yeah, I think you can.
Yeah. I have a question, Professor Zivadinov. Thank you very much indeed, your presentation. I would like to know your opinion about, as we know, multiple sclerosis patients has a disability, mostly because of the cervical lesions and cervical atrophy. And do we, at the moment, we don't have a good analysis system in MRI. So do you think that in the future we will have a chance to analyze this cervical region, cervical spinal cord, advancing new techniques? What do you say about this?
So that's a great question, and there have been a couple of really recent, very recent studies which compared how the development of cervical cord atrophy correlates with the development of pontocerebellar atrophy. As you know, they are very close to each other, and there have been a couple of indexes proposed in which they found extremely good correlations and validated on close to 1,000 subjects data sets the validity of the cervical versus pontocerebellar atrophy. Now, this is another tool that it's fully automated, and this work has been published in Journal of Neuroimaging, and I think can be used as a proxy of the cervical cord atrophy. Now, if you ask me, are we going to be able to run a second scan? No, if not needed, because it's really insurance-driven, and it's timing and it's everything. So I think that to have an idea of how the infratentorial part of the brain is doing, I think it's very close to what's happening in the cervical cord.
Thank you very much indeed.
I would also just add maybe to the previous discussion that it's extremely important to begin think about using these quantitative measures in terms of treatment decisions, because we know that following patients by looking on the new or enlarging lesions largely is failing to recognize who are the patients who are going to progress and who are those patients who are not. So introducing more at least quantitative, whether manually or automatically obtained metrics, is going to be critical in trying to determine freedom from the disease.
And probably to add this, because we are, of course, looking for very small structural changes which are there in the beginning. I think the same should be true, and that is, again, one of our philosophies, to create software, a software which is able not only to detect disability when it's visible, but to develop tools which is able to detect functional changes in the beginning. Because I think we have to get earlier regarding imaging parameters, we have to get earlier about functional parameters. And I think regarding this, computer technology, collecting data, using intelligent software system can help a lot.
I might close this symposium with just a couple of concluding remarks, really. The main one is that we're all quite positive up here. We're positive that increased precision in monitoring is not a dream for the distant future, but that we will be able to access both measures such as cognition and quantitative MRI and join them with our clinical outcome measures to improve treatment and treatment failure definitions and paradigms. And I hope that that dream will become a reality within the next year or two, actually. So on that positive note, I want to thank all of you for attending. I want to thank our wonderful chair and the rest of the panel, and wish you a really wonderful and productive and educational time for the rest of this wonderful Congress. Thank you.
Thank you very much indeed. It was very nice.